Welcome back to the Deep Dive. We're here to help you build that real functional mastery over complex professional knowledge.
That's the goal.
And today, we have a really critical mission ahead of us. We're aiming for elite competence in the foundational diagnostic tools in obstetrics.
Exactly. And this isn't just, running through a list of tests. We're really dissecting the core principles, the physics, the techniques, and maybe most importantly, how clinicians interpret all these essential assessments.
Everything from imaging to labs.
Right. From the non-invasive stuff right through to the essential lab diagnostics. So if your aim is to truly understand how the best clinicians see, measure, and diagnose during pregnancy, well, this is the deep dive for you.
Okay, let's dive in. Starting with the bedrock principles of diagnostic imaging. The source material lays out a pretty clear hierarchy for indications, doesn't it?
It does. Imaging is indicated only for a specific diagnosis or maybe therapy directed at either the fetus or the mother. That's the starting point.
But right away, we hit that central challenge in obstetrics.
The big one. Balancing the need to know the diagnostic necessity with keeping fetal risk absolutely minimal, especially when we talk about radiation.
This safety framework seems non-negotiable. The source stresses mastering these rules.
It's paramount, absolutely. Rule number 1. The clinical benefits of any radiation exposure must clearly outweigh the known or potential risks to the fetus. Always.
If that balance isn't heavily weighted towards benefit,
then you just don't do it. Simple as that. The procedure can't proceed.
And even when it is necessary, there are strict dose limits we need to know cold.
Correct. Always use the minimum effective radiation dose. For diagnostics, the standard threshold you really don't want to significantly exceed is less than 5 rad.
5 rad, that's the critical number.
That's your number. Going above that, especially in the first trimester, the risks start to climb noticeably. And of course, always use appropriate fetal shielding whenever feasible.
Why is that first trimester timing so critical? You mentioned the vulnerability.
Yeah, it's all about organogenesis. That period, roughly weeks 3 through 8 after conception, is when the major organs are forming. That's when the fetus is most susceptible to teratogenic effects from radiation.
So the guideline is pretty clear.
Avoid it if you can. The first trimester should preferably be avoided entirely for radiation exposure. If there's a way to get the answer using non-ionizing methods, you default to that.
Which brings us straight to the main alternatives.
Ultrasonography, USG, and magnetic resonance imaging, or MRI. These are your frontline tools precisely because they don't use ionizing radiation.
Okay, so USG. It really is the workhorse in obstetrics, isn't it? Let's start right at the beginning of the definition. The physics, we're talking sound waves.
Exactly. Sound waves with a frequency higher than humans can hear, typically greater than 2 megahertz.
And its origins are interesting, tracing back to sonar.
Right. Sonar. Sound, navigation, and ranging. Military tech initially. But the clinical revolution, especially in obstetrics, that really kicked off with Ian Donald in Glasgow back in 1958. That's when it shifted from just detection to actual diagnostic visualization.
That's quite a leap. So the mechanism itself. How do we get from electricity to an image using sound?
It's quite elegant, actually. It all happens in the transducer, specifically with a synthetic piezoelectric crystal. You apply electrical energy, the crystal vibrates mechanically, and boom, sound waves.
And then the reverse happens for the image.
Precisely. The sound waves travel out, hit structures, and bounce back as echoes. When those echoes hit the crystal, it vibrates again, converting that mechanical energy back into electrical energy, a signal. The machine processes those signals to build the image on the screen.
And the frequency of those waves is key to what we can actually see.
Absolutely. We tailor the frequency. For transabdominal scans going through the abdominal wall, you need penetration, so you use lower frequencies, maybe 3 to 5 megahertz.
But for transvaginal?
For transvaginal, the probe is much closer to the uterus and early pregnancy structures. So you can use higher frequencies like 5 to 7 megahertz because you don't need as much penetration.
Which gets us to that fundamental trade-off in ultrasound physics. Resolution versus penetration. This is where it gets really practical.
This is absolutely core to understanding USG. Increase the frequency, you get more sound waves hitting the tissue per second. That means much better image resolution, sharper, clearer pictures.
But there's a catch.
There's always a catch. Higher frequency waves attenuate faster. They lose energy more quickly as they pass through tissue. The result, poor penetration of deeper structures. So you're constantly balancing, do I need crystal clarity nearby or do I need to see something deep inside?
Okay, so the waves go out, they bounce back. The image depends on how strong those returning echoes are. What makes an echo strong? Creating a bright spot on the screen.
The source lists 4 main factors. The biggest one is acoustic impedance mismatch.
Impedance mismatch. Explain that a bit.
Acoustic impedance is basically how much resistance a material offers to sound waves passing through it. The bigger the difference, the mismatch in impedance between 2 adjacent tissues, the more sound gets reflected back.
Like soft tissue next to bone.
Perfect example. Huge density difference, massive impedance mismatch, so you get maximum reflection. That's why bone shows up as bright white or highly echogenic on the ultrasound.
The angle of the beam matters too, right?
Definitely. Factor number 2, beam angle. The closer the ultrasound beam hits a structure at a perpendicular angle straight on, the stronger the echo bouncing back. Hit it at an oblique angle and the sound scatters, giving you a weaker, fuzzier image.
What are the other 2 factors?
Third is just the initial strength of the ultrasound pulse sent out by the transducer. More power in, potentially more echo back. And fourth is simply the size of the thing reflecting the sound. A big structure like the fetal femur reflects a lot of sound, so it's very echogenic.
Whereas smaller things.
Smaller things, like maybe the renal pelvises, they tend to scatter the sound more diffusely. That gives you that kind of granular, less distinct speckle pattern you often see in tissues.
Got it. Let's talk about how we actually see this information displayed, the standard modes.
Primarily, we use B mode. That stands for brightness mode. It's your standard 2D black and white image. The brightness of each dot corresponds to the strength of the echo received from that point. It gives you width and brightness.
And M mode.
M mode is for motion. It's specifically designed for looking at moving structures, most famously the fetal heart. It displays movement along a single line over time, creating that characteristic wavy pattern which lets us measure things like heart rate and chamber dimensions very accurately.
Now, let's bring movement into the picture in a different way with Doppler ultrasound.
Mm-hmm.
This is crucial for blood flow.
Absolutely. This relies on the Doppler effect, described by Christian Doppler way back. The basic idea is a frequency shift. When the ultrasound wave hits moving red blood cells, the frequency of the reflected wave changes.
It shifts up or down depending on direction.
Exactly. If the blood cells are moving towards the transducer, the frequency increases. If they're moving away, it decreases. By measuring that frequency shift, we can figure out the velocity and direction of blood flow.
And we see this visually with the flow velocity waveform, the FVW, often using color.
Right. Color Doppler is incredibly useful for a quick visual assessment. Conventionally, flow towards the transducer is coded red, flow away is blue. The brightness of the color often indicates velocity. Its purpose is clear. Show if blood is flowing, which way it's going, and how fast in vessels like the umbilical artery or the fetal brain arteries.
Moving beyond 2D slices, we have 3D ultrasonography. How does the machine capture a whole volume?
Instead of just one flat plane, the ultrasound beam is swept across the area of interest, either mechanically or electronically, in 2 perpendicular planes. It's like taking a whole series of slices very quickly. This captures a block or volume of echo data.
And that data is stored.
Digitally stored. The power comes from the computer software, which can then take that stored volume and reslice it in any plane you want after the scan is done. You can look at it from angles you couldn't get in real time.
What are the big advantages of doing this? Why use 3D?
Several key benefits. First, it helps visualize complex anatomy. Think about a fetal face with a cleft lip, or intricate heart structures. 3D lets you see the whole thing in one view without having to mentally piece together multiple 2D slices.
That must help with diagnosis.
Immensely. Plus, the stored volume allows for secondary review, getting a second opinion, or even diagnosing something later. It's also fantastic for teaching. And quantitatively, 3D is better for calculating volumes like fetal lung volume to predict hypoplasia risk.
And we can't forget the impact on parents.
True. Those lifelike 3D and 4D, which is real-time 3D images, definitely enhance antenatal bonding for many parents. It makes the baby feel more real.
But there's an important caveat from ACOG, the American College of Obstetricians and Gynecologists.
A very important one. ACOG is clear. 3D ultrasound is an adjunct to standard 2D ultrasound. It does not replace it. The fundamental anatomical survey must still be done thoroughly using 2D. 3D is a supplementary tool for specific situations.
Okay, circling back to safety, always critical. What are the known biological effects of ultrasound energy on tissues?
The main potential effects are thermal, basically, heating of the tissues, and mechanical effects like cavitation, which is the formation and collapse of microbubbles.
But is there evidence of actual harm?
Based on decades of use and extensive research, the current consensus is that there's no clear, confirmed evidence of harm to the fetus when diagnostic ultrasound is used properly, meaning for valid medical reasons, for the shortest possible time, following the Allaire principle.
Val.
As low as reasonably achievable. Minimum exposure for the necessary information.
But Doppler gets a specific warning. Why is Doppler different?
Doppler requires significantly higher energy output, higher power, compared to standard B-mode imaging. You need that extra power to detect the weak echoes from tiny moving red blood cells.
And there's a limit.
Yes, there's an established upper safe limit for the power output, which is 1,000 milliwatts per square centimeter. This is why purely recreational or keepsake Doppler scans, especially long ones, are strongly discouraged by medical bodies. The potential for tissue heating is higher.
Good point. Lastly, for this section, let's talk transvaginal ultrasound, TVS. Why is it the go-to for early pregnancy?
Location, location, location. In the first trimester, the uterus is still tucked down low in the pelvis. A transabdominal probe has to send sound waves through the abdominal wall, fat, maybe bowel gas. Lots of attenuation.
But TVS gets closer.
Much closer. The transvaginal probe is right up against the cervix, very close to the uterus and the early gestational sac. This means minimal signal loss, less attenuation. So you can use higher frequencies, which gives you much better tissue resolution. You can see the tiny details, the yolk sac, the early embryo, much clearer and earlier with TVS.
All right, let's apply this clinically. First trimester USG is primarily about dating and viability. What are the high-yield indications we absolutely need to know?
Top of the list. Confirming it's an intrauterine pregnancy, an IUP. Then ruling out ectopic or molar pregnancy, especially if there's bleeding. Assessing vaginal bleeding itself, determining chorionicity if it's twins or more, confirming there's a heartbeat fetal cardiac activity. And of course, it's crucial for aneuploidy screening, especially measuring the neutral translucency.
There's a key correlation between what we see and the maternal beta HCG levels, right? The human chorionic gonadotropin.
Absolute critical. With transvaginal ultrasound, you should definitely see an intrauterine gestational sac once the beta HCG level hits around 1,000 to 1,200 milli-international units per milliliter.
And if you're using transabdominal?
You need a much higher level, typically around 6,000 MIU/mL, because it's just harder to see that early. Later, the yolk sac usually appears around 7,000, and you should see an embryo by about 11,000 MIU/mL.
So if the HCG is above that 1,200 TVS threshold and you see nothing in the uterus?
Then you have to be highly suspicious of an ectopic pregnancy. That's a key diagnostic point.
And when you do see a sac, you need to be sure it's a true gestational sac, not a pseudo-sac. What are the signs?
A true gestational sac, the GS, has a couple of features. It's usually eccentric, meaning it's implanted off to one side within the endometrial cavity, not dead center. And it should have the double deciduous sign that's two concentric echogenic rings surrounding part of the sac.
What about a pseudo-sac?
A pseudogestational sac, which can happen with an ectopic pregnancy, tends to be more centrally located within the endometrial cavity. It's often irregular in shape. It lacks that double deciduous sign, and importantly, it's empty, just fluid collection.
For dating, the crown rump length, or CRL, is king in the first trimester.
It's the most accurate biometric parameter we have early on. The error margin is tiny, only about 2.1 days. There's a rough rule of thumb. CRL in millimeters plus 42 gives you the approximate gestational age in days.
But it loses accuracy later.
Dramatically. After about 12 or 13 weeks, the fetus starts to flex and extend more, making the CRL measurement less reliable. That's when we switch to other parameter.
We also measure the mean sac diameter, MSD.
Yes, MSD in millimeters plus 30 is another way to estimate gestational age in days, though it's less accurate than CRL. But the MSD has a critical red flag associated with it.
Which is?
If the mean sac diameter reaches 6 millimeters on transvaginal scan, and you still can't see an embryo within it, that's considered diagnostic of pregnancy loss.
Let's touch on early genetic markers visible in USG.
The main one is increased neutral translucency, the NT. This is the fluid collection at the back of the fetal neck. Measured via TVS, ideally between 11 and 14 weeks, an NT greater than 3 millimeters is a significant marker.
It's not specific to one condition, though.
No, it's a nonspecific but strong marker for an increased risk of major chromosomal abnormalities like trisomy 21, Down syndrome, trisomy 18, trisomy 13, triploidy, and Turner syndrome. A thick NT definitely warrants further investigation, usually with genetic counseling and diagnostic testing options.
And finally, back to ectopic pregnancy, using Doppler to help confirm.
TVS itself is very good, finding about 90% of ectopics. But sometimes you might see an adnexal mass that's suspicious. Color Doppler can be really helpful by showing the ring of fire.
The ring of fire.
Yeah, it's this ring of increased vascularity around the ectopic gestational sac. It represents the blood flow in the trophoblastic tissue that's implanted outside the uterus. Seeing that characteristic high-velocity, low-resistance flow pattern really strengthens the diagnosis of ectopic pregnancy.
Okay, moving into the mid and third trimesters. The focus shifts more towards growth and detailed anatomy. What are the main reasons for scans now?
It becomes much more comprehensive. We're assessing gestational age if it wasn't done earlier, looking closely at amniotic fluid volume, checking the placenta's location and health, ruling out previa or signs of abruption. A huge focus is monitoring fetal growth, looking for fetal growth restriction or FGR.
And assessing well-being.
Yes, performing the biophysical profile, the BPP, which combines ultrasound markers with a non-stress test. And ultrasound is absolutely essential for guiding invasive procedures safely, like amniocentesis, chorionic villus sampling, CVS, or corticentesis.
If dating is needed in the second trimester, when's the best time?
The sweet spot for accuracy is between 14 and 20 weeks, and the rule for practice is really important here. Any dating ultrasound done before 22 weeks should be considered more reliable than the patient's last menstrual period, or LMP, for setting the estimated due date, even if the patient is sure about her dates.
Got it. Let's review the key biometric measurements: head measurements, biparietal diameter, BPD, and head circumference, HEC. How do we ensure consistency?
Standardization is everything. These measurements must be taken in a specific transverse view of the fetal head. You need to see three landmarks clearly: the falx cerebri splitting the hemispheres, the cavum septum pellucidum, a fluid space midline, and the thalami.
And the BPD measurement itself.
It's measured from the outer edge of the upper skull bone to the inner edge of the lower skull bone, outer to inner. HC is measured around the outer perimeter of the skull at the same level. Getting this plane right is crucial for tracking growth accurately over time.
What about the abdominal circumference, AC?
AC is measured in a transverse section of the fetal abdomen, ideally as circular as possible. The key landmark is the junction of the umbilical vein with the portal sinus, specifically where the left and right portal veins join. You should also see the fetal stomach bubble on that image.
And why is AC so important?
Because the AC is the single most sensitive parameter for assessing fetal growth and nutrition. The liver is a big component of the AC, and it's one of the first organs affected by growth restriction. If the AC starts lagging, that's often the earliest sign something is wrong. We also measure the femur length, FL, as a marker of skeletal growth.
You also mentioned the transcerebellar diameter, TCD. What's its special utility?
The TCD is measured across the cerebellum in the posterior fossa. Its value lies in the fact that it's a very accurate predictor of gestational age, especially between 14 and 28 weeks. And crucially, it's often spared in cases of growth restriction.
So if other measurements are off.
If the BPD and AC suggest the baby is small for dates, but the TCD matches the expected age, it can help confirm the gestational age and points more towards an asymmetric growth problem rather than an issue with the original dating.
We use all these measurements to estimate fetal weight. How accurate is that?
We plug BPD, HC, AC, and FL into formulas, like the Hadlock formula, which is common. These formulas are pretty good, statistically sensitive to within about 7.5% of the actual birth weight. However,
There's a but.
there's a significant but. The individual variation can be quite large, typically around 16 to 20%. So an estimated weight of, say, 3,000 grams could easily mean the baby is actually 2,500 grams or 3,500 grams. It's an estimate, not a precise measurement, and needs to be interpreted with that caution.
This growth data lets us differentiate types of intrauterine growth restriction, IUGR, asymmetric versus symmetric. This distinction is clinically vital.
Absolutely vital, because it points towards different underlying causes and prognosis. In asymmetric IUGR, the insult usually happens later in pregnancy, often due to placental insufficiency. The fetus adapts by shunting blood flow to vital organs, primarily the brain.
A brain-sparing effect.
Exactly. So the head circumference, HC growth, is relatively preserved, but the abdominal circumference, AC, reflecting liver size and subcutaneous fat, falls off significantly, usually after 30 weeks. This leads to an elevated HC to AC ratio.
And symmetric UDR.
Symmetric IUGR implies an insult that occurred much earlier in gestation, affecting overall cell number and growth potential. things like chromosomal abnormalities, congenital infections, or early teratogen exposure. In these cases, both the head and the abdomen are small, so the HC and AC are proportionally reduced, and the HC to AC ratio typically remains normal. The prognosis for symmetric IUGR is often more guarded.
Beyond measurements, a detailed anatomical survey is mandatory. What are the absolute essential elements according to standards like ACR?
You need a systematic check. This includes the cerebellum, the cisterna magna, the fluid space behind it, a clear four-chamber view of the heart, views of the outflow tracts, aorta and pulmonary artery, visualizing the stomach, both kidneys, the bladder, the umbilical cord insertion into the abdomen, checking for 3 vessels in the cord, imaging the entire spine in multiple planes, and assessing all 4 extremities.
Let's focus on neural tube defects, NTDs. There are specific cranial signs that are huge clues for spina bifida.
Yes, the so-called intracranial signs of open spina bifida linked to the Arnold-Chiari II ad formation. Finding these should prompt a very careful look at the spine. The key signs are, first, obliteration of the cisterna magna because the cerebellum is pulled down.
And the shape changes.
Right. Second, the banana sign, the cerebellum gets compressed and flattened against the occiput, looking like a banana. Third, the lemon sign, the frontal bones of the skull become scalloped or indented, resembling a lemon. Seeing these strongly suggests an open spinal defect lower down.
What about the most severe brain defect?
Anencephaly, the absence of the cranial vault, and most of the brain is usually diagnosable quite early, often around 13 weeks. For spinal defects themselves, we need to distinguish spina bifida occulta, where the bone defect is covered by skin, from spina bifida aperta.
Aperta being the open one.
Correct. Aperta is a full-thickness defect where the neural tissue is exposed, sometimes covered by just a thin membrane, like a meningocilla, meninges only, or myelomeningocele, meninges and neural tissue.
Moving to the abdomen again, what are key things to look for?
You should always see the stomach bubble, usually by 20 weeks. If it's persistently absent, especially with polyhydramnios, you have to suspect esophageal atresia. Another important finding is hyperechoic bowel.
Brighter than bone.
Exactly. When the fetal bowel looks as bright as or brighter than nearby bone, it's a red flag. It's associated with several things, including chromosomal abnormalities, especially trisomies 13 and 18, cystic fibrosis, and intrauterine infections like CMV.
Now, a critical differentiation. Gastroschisis versus omphalocele. Getting this right is crucial for prognosis and counseling.
Absolutely critical distinction. Gastroschisis is a defect usually to the right of a normally inserted umbilical cord. It's typically small bowel loops that herniate out and float freely in the amniotic fluid. The key feature? There is no covering membrane.
And the prognosis. Associated risks.
Prognosis for gastroschisis is generally good with surgical repair after birth. Importantly, it's usually not associated with chromosomal abnormalities.
Contrast that sharply with omphalocele.
Omphalocele is typically a midline defect at the base of the umbilical cord the cord inserts onto the sac. The herniated contents can include bowel, liver, or both. The absolute key difference. The herniated organs are covered by a membrane composed of amnion and peritoneum.
And the associated risks are much higher.
Much higher. Omphalocele has a strong association with chromosomal abnormalities, somewhere between 40 to 60% of cases. It's also linked to other major structural defects, particularly cardiac ones, so the prognosis is often poorer, and genetic testing is essential.
Let's shift to the placenta cord and fluid. How do we define placenta previa on ultrasound relative to the cervix?
Placenta previa means the placenta is covering or encroaching upon the internal cervical os. For practical management, we generally consider it safe to allow a trial of vaginal delivery if the lower edge of the placenta is clearly more than 20 millimeters or 2 centimeters away from the internal os on a 3rd trimester scan.
Does a low-lying placenta early on always mean previa at term?
No, actually. Many placentas that appear low-lying in the 2nd trimester will effectively migrate upwards as the lower uterine segment develops and stretches. Only about 5% of those diagnosed as low-lying mid-pregnancy actually persist as a true previa requiring C-section at term. Follow-up scans are key.
In twins, determining chorionicity is vital for risk assessment, like for TTTS. How do we tell DD from monoday?
For diamniotic dichorionic di twins, which can be fraternal or identical, the classic sign is the twin peak sign, or lambda sign. This is a triangular projection of placental tissue seen extending into the base of the dividing membrane between the sacs. Also, the dividing membrane itself is thick, usually greater than 2 millimeters.
And for monochorionic diamniotic monoday twins, always identical.
Right. Because they share a chorion, the dividing membrane is very thin, less than 2 millimeters, as it's only made of 2 layers of amnion. At the point where the membrane meets the shared placenta, it forms a perpendicular junction, like the letter T, that's the T sign. Seeing a T sign points strongly to monochorionicity.
What about the scary placenta accreta spectrum? What are the ultrasound clues, especially if there's a history of C-section?
The first clue might be the loss of that normal clear space, the retroplacental sonolucent zone, between the placenta and the myometrium. Doppler is extremely helpful here.
How so?
Doppler shows abnormal vascularity, turbulent flow within large vascular lakes or lacunae within the placenta, hypervascularity at the uterine bladder interface, and vessels appearing to cross from the placenta directly into the myometrium or beyond. MRI is often used to confirm the depth.
Increta versus percreta.
Accreta just means abnormally adherent. Increta means the villi invade into the myometrium. Percreta is the most severe, where the villi invade through the myometrium, potentially reaching the uterine serosa or even adjacent organs like the bladder.
The umbilical cord itself can give clues. What's the significance of a single umbilical artery, SUA?
Finding only 2 vessels, 1 artery, 1 vein, instead of the usual 3 is significant. SUA is associated with an increased risk of other fetal anomalies, somewhere in the range of 30 to 70%. You need to do a thorough anatomical survey, paying special attention to the cardiac system, the central nervous system, and the kidneys.
Lastly, for this part, amniotic fluid volume. How do we define polyhydramnios? Too much fluid.
Polyhydramnios is diagnosed if the amniotic fluid index, the AFI, which sums the deepest vertical pocket in 4 quadrants, is greater than 25 centimeters. Or, alternatively, if the single largest vertical pocket, LVP, measures more than 8 centimeters. This needs investigation for underlying causes like diabetes or fetal anomalies.
Okay, back to Doppler, but focusing on the numbers, the indices and flow patterns that tell us about fetal well-being.
We use color Doppler to see the flow, but pulse Doppler gives us the quantitative data. We measure the peak systolic velocity, S, the end diastolic velocity, D, and calculate indices like the resistance index, RI, the pulsatility index, PI, and the simple SD ratio.
What does reduced diastolic flow generally indicate?
Low or absent diastolic flow means high resistance to blood flow downstream from where you're measuring. In fetal circulation, this usually means poor perfusion of the organ or vascular bed being supplied. It's a sign of compromise.
Let's start on the maternal side, the uterine artery Doppler. What's the significance of a notch?
A notch is a persistent dip in the waveform during early diastole. Seeing this, especially if it's bilateral in both uterine arteries and persists beyond about 24 weeks, indicates high resistance in the uteroplacental circulation. It's thought to reflect incomplete invasion of the spiral arteries by the trophoblast.
And its predictive value.
It's a strong predictor for developing complications later in pregnancy, specifically preeclampsia and fetal growth restriction.
Now, shifting to the fetal side, the umbilical artery, UA Doppler, what are the key thresholds after 30 weeks?
After 30 weeks, placental resistance normally decreases, so diastolic flow should increase. The SD ratio should ideally be less than 3 if it's higher, or if the diastolic flow becomes absent.
Absent end diastolic flow, AEDF.
That's a very concerning sign. It's associated with about a 16% risk of fetal death. But even worse is reversed end diastolic flow, REDF.
Where blood flows backward in diastole.
Exactly. That indicates extremely high resistance, severe fetal compromise, often hypoxia and acidemia. REDF in the umbilical artery carries a fetal death rate risk approaching 50%. Finding this often prompts urgent delivery discussions.
How does a fetus try to cope with this? That leads us to the middle cerebral artery, the MCA.
The fetus initiates the brain-sparing response. To protect the brain in times of hypoxia, peripheral vascular beds constrict, increasing resistance there, like in the umbilical artery, while the cerebral vessels dilate to maximize blood flow to the brain.
How do we see that on Doppler?
We see increased diastolic flow in the middle cerebral artery, meaning lower resistance. So you might see a high SD ratio in the umbilical artery, but a low SD ratio in the MCA. This pattern of centralization is a clear sign of fetal adaptation to stress. If you see this along with absent flow in the aorta, it suggests significant fetal acidemia.
The MCA Doppler has another critical use related to anemia.
Yes, measuring the peak systolic velocity, PSV, in the MCA. In fetal anemia, typically from Rh isoimmunization or other causes, the blood is thinner, less viscous, so it flows faster.
And there's a threshold for concern.
A middle cerebral artery peak systolic velocity greater than 1.5 times the median value for that gestational age, 1.5 mom, is a highly sensitive and specific non-invasive predictor of moderate to severe fetal anemia.
What does that finding trigger?
It's usually a direct indication for invasive testing via cortocentesis, sampling fetal blood, and potential intrauterine blood transfusion.
Okay, finally for ultrasound, let's quickly recap some key genetic sonography associations, specific ultrasound findings linked to chromosomal issues. These are vital for counseling.
Right. Need to know these. Choroid plexus cysts, while often transient and benign, are soft markers for trisomy 18 and sometimes 13. The characteristic strawberry skull shape is strongly linked to trisomy 18. Polydactyly, extra finger stows, is common in trisomy 13.
And abdominal findings.
Echogenic bowel, as we mentioned, is associated with trisomy 13 and 18, as well as 21. And omphalocele has that very high association with trisomy 13, 18, and 21. Recognizing these patterns is key to guiding appropriate further testing.
We've covered USG in depth, but sometimes we need more detail, especially for complex cases. That brings us to magnetic resonance imaging, MRI. How does it work fundamentally without using radiation?
It's based on magnetism and radio waves. Very powerful magnets align the body's hydrogen protons, basically, the protons in water molecules. Then radio frequency pulses are sent in, which temporarily knock these aligned protons out of alignment.
And the image comes from them going back.
Exactly. When the radio pulse stops, the protons relax back into alignment with the main magnetic field. As they relax, they emit faint radio signals. The MRI scanner detects these signals, and complex computer algorithms use the timing and location of these signals to construct incredibly detailed cross-sectional images.
The huge advantage. No ionizing radiation.
Zero ionizing radiation. That's why its safety profile in pregnancy is so good. Studies using magnets up to 1.5 Tesla strength haven't shown any harmful effects on the fetus at any gestational age, so it's considered safe when indicated.
But what about contrast agents? Gadolinium.
That requires caution. Gadolinium-based contrast agents do cross the placenta and enter the fetal circulation and amniotic fluid. While direct fetal harm seems rare, there are theoretical concerns about long-term retention. It's classified as a Category C drug.
The rule is?
Avoid it completely in the first trimester. Later in pregnancy, use it only if absolutely necessary for critical maternal or fetal diagnosis where the benefits clearly outweigh any potential risks. And informed consent is crucial.
Where does MRI really outperform or significantly add to what ultrasound can do?
It excels in several areas.
Yeah.
For complex fetal anomalies, especially in the brain, like subtle migration abnormalities or posterior fossa issues, their chest or the genitourinary system, MRI provides superior soft tissue contrast and detail compared to USG.
What about estimating weight?
Interestingly, some studies suggest newer MRI techniques might actually be more accurate than ultrasound for estimating fetal weight, though it's not routinely used for that. It's also excellent for evaluating maternal conditions during pregnancy, like pelvic masses or suspected appendicitis, where radiation is a concern.
And its role in placenta accreta seems particularly important.
Indispensable, really.
Yeah.
While Doppler USG gives clues, MRI, particularly using T2-weighted images, is often better at defining the exact depth of placental invasion into the uterine wall, differentiating accreta, increta, and percreta. It can show uterine bulging, dark placental bands invading the muscle, and loss of normal tissue planes, which is critical for surgical planning.
Does it play a role in fetal therapy planning?
Yes, it's sometimes used as an adjunct imaging tool before complex fetal interventions. For example, getting detailed anatomy before laser ablation for twin-to-twin transfusion syndrome, TTTS, or before fetal surgery for conditions like spina bifida or congenital diaphragmatic hernia.
And who absolutely cannot have an MRI?
Anyone with implanted electronic devices like cardiac pacemakers or defibrillators, certain types of aneurysm clips, cochlear implants, or other significant ferromagnetic metal implants. The powerful magnetic field poses a serious risk to these patients.
Okay, now we have to confront the imaging modalities that do use ionizing radiation, starting with computed tomography, CT.
Right. CT uses X-rays to create cross-sectional images, often in a spiral or helical fashion with modern multi-detector CT, MDCT scanners. While fast and excellent for many conditions, the radiation dose can be significant, often higher with MDCT compared to older techniques.
So the stance in pregnancy is clear avoidance if possible.
Absolutely. CT should be avoided in all trimesters unless it's absolutely essential for a life-threatening maternal condition, and the diagnostic information cannot be obtained reasonably using USG or MRI.
The primary concern isn't necessarily birth defects at diagnostic doses, but rather
The long-term risk of carcinogenesis. Even low doses of radiation exposure in utero are thought to slightly increase the child's lifetime risk of developing cancer. while the risk of teratogenesis, causing birth defects, is low below the 5 rad threshold. The cancer risk is always a consideration.
So when is CT justified in pregnancy? What are the key indications?
The classic indication is a CT pulmonary angiogram, CTPA, for a suspected pulmonary embolism in a hemodynamically unstable or critically ill mother where a rapid diagnosis is vital. Another might be a cranial CT if an eclamptic patient has focal neurological signs suggesting stroke or hemorrhage.
Do we know the typical fetal dose for these?
For a CTPA, the direct fetal dose is usually quite low, but scatter matters. For something like CT pelvimetry, which is rarely done anymore, the dose was estimated at 0.25 to 1.5 rad, still generally below that 5 rad first trimester threshold.
What about standard X-rays for radiology? Their role seems to be shrinking.
It's definitely declining. With the quality and safety of USG and MRI, standard X-rays have fewer indications. They might still be used occasionally to assess complex fetal skeletal malformations late in pregnancy, evaluate suspected birth injuries, or for maternal issues like pneumonia requiring a chest X-ray.
If a chest X-ray is needed.
If absolutely necessary, it should ideally be done after the first trimester, beyond 12 weeks, with proper abdominal shielding to minimize fetal exposure. The dose from a single chest X-ray is very low.
We really need to nail down these radiation hazard thresholds and timing rules. This is high-stakes knowledge for counseling patients.
Couldn't agree more. The risk depends heavily on two things: the radiation dose and the gestational age at exposure. The period of maximum risk for major malformations is during organogenesis, essentially the first trimester, particularly after the first 2 weeks post-conception.
What are those critical dose thresholds for counseling?
Exposure above 5 rad during the first trimester or above 15 rad during the second or third trimester is considered significant enough to require detailed counseling about potential risks. Exposure above 5 rad in the first trimester might even lead to discussions about pregnancy termination options, although it's crucial to emphasize that most standard diagnostic procedures deliver doses well below 5 rad. Exposures in that typical diagnostic range are generally not associated with a measurable increase in congenital malformations.
Can you explain the all or none phenomenon again? That applies very early on.
Right. This is specific to radiation exposure within the first 2 weeks after conception, before implantation and major organogenesis really begin. At this stage, the conceptus is basically a small ball of undifferentiated cells. Significant radiation exposure will either destroy enough cells to cause demise of the entire embryo, leading to miscarriage, the all part, or the remaining cells can compensate and development proceeds normally, the none part. You don't tend to see structural malformations from exposure in this very early window.
And the practical rule designed to prevent accidental exposure in early pregnancy.
That's the 10-day rule. It's a cornerstone of radiological safety for women of childbearing potential. It states that non-urgent radiological examinations involving the pelvis or lower abdomen should ideally be scheduled within the first 10 days following the onset of the last menstrual period, LMP.
Why those 10 days?
Because ovulation typically occurs around day 14, so performing the X-ray in the first 10 days makes it highly unlikely that the woman is pregnant, thus avoiding inadvertent irradiation of a potentially unrecognized early pregnancy during its most sensitive developmental phase.
Okay, let's move from imaging to invasive procedures. Amniocentesis is a key one. Definition first. It's deliberately puncturing the amniotic sac through the abdomen. Why do we do it? The indications depend on timing.
Correct. In the second trimester, typically between 15 and 20 weeks, it's primarily for diagnostic purposes. This is genetic amniocentesis. We collect amniotic fluid to get fetal cells for karyotyping, checking chromosomes, specific genetic testing for single gene disorders, diagnosing inborn errors of metabolism, and measuring alpha-fetoprotein, AFP levels to screen for neural tube defects.
And if it's done later in pregnancy, the goals shift.
Yes, later on, the diagnostic focus is more on fetal well-being and maturity. We might do an amnio to assess fetal lung maturity before a planned preterm delivery. In cases of Rh sensitization, we analyze the fluid spectrophotometrically, looking for that bilirubin bulge at 450 nanometers to gauge the severity of fetal hemolysis.
Can it detect distress?
It can detect meconium staining in the fluid, which can be a sign of past or ongoing fetal distress, although its predictive value is debated.
Amnio also has therapeutic uses, again split by timing. First half of pregnancy.
Historically, therapeutic amnio in the first half was sometimes used for pregnancy termination by instilling agents like hypertonic saline or prostaglandins. More commonly now, it might be used for repeated amnioreduction, removing excess fluid in cases of severe acute polyhydramnios, causing significant maternal discomfort or respiratory compromise.
And therapeutic uses in the second half.
Amnioreduction for chronic polyhydramnios can still be done to relieve maternal symptoms or potentially prevent preterm labor. And crucially, amniocentesis can be part of the procedure for performing an intrauterine fetal blood transfusion, guiding the needle for cortocentesis in severely anemic fetuses.
There's also a related procedure called amnioinfusion. What's that?
Amnioinfusion is the opposite. It's infusing fluid into the amniotic cavity, usually warm, normal saline. It can be done either transabdominally, like an amnio, or transcervically during labor.
Why would you infuse fluid?
The main indications are, 1, to treat oligohydramnios, low fluid, either to try and prevent fetal lung hypoplasia or, more commonly during labor, to cushion the umbilical cord and hopefully relieve variable decelerations caused by cord compression. 2, it's sometimes used to dilute thick meconium in the fluid, aiming to reduce the risk or severity of meconium aspiration syndrome, though evidence for this is mixed.
Let's get into the amniocentesis procedure itself. Technique and safety are paramount. Real-time imaging is key.
Absolutely non-negotiable. The patient is usually positioned comfortably, the abdomen is prepped aseptically, and local anesthetic, like 1% like nocaine, is infiltrated. Then, a spinal needle, typically 20 or 22 gauge with a stylet, is inserted through the abdominal wall and uterine wall into the amniotic sac.
Under continuous guidance.
Under continuous, real-time ultrasound guidance, you watch the needle tip the entire way. This minimizes the risk of hitting the fetus, hitting the placenta, causing significant bleeding, getting a dry tap, no fluid, or needing multiple painful attempts. It's the standard of care.
How is the fluid handled once you're in?
Once you have free flow of fluid, the first 1 to 2 milliliters are usually discarded. This is important because that initial fluid might contain maternal cells sloughed off during needle passage, which could contaminate a genetic analysis.
How much is typically collected?
For standard karyotyping and genetic studies, about 20 to 30 milliliters of amniotic fluid is usually sufficient. After withdrawing the needle, you always check for fetal cardiac activity again on ultrasound.
What are the absolutely critical safety precautions?
First, always do a preliminary ultrasound to precisely locate the placenta and find a safe pocket of fluid away from the fetus and major placental vessels. Second, for all Rh-negative mothers who are not already sensitized, prophylactic administration of anti-deimmunoglobulin, like Rojam, usually 100 or 300 micrograms depending on gestation, is mandatory immediately after the procedure.
Why the anti-D?
To prevent Rh sensitization, even a small amount of fetal blood entering the maternal circulation during the procedure, fetal-maternal hemorrhage, could trigger an immune response in an Rh-negative mother if the fetus is Rh positive. Anti-D prevents this.
Even with ultrasound guidance, there are still risks, hazards we need to counsel patients about.
Yes, it's an invasive procedure. Maternal risks include infection, chorioamnionitis, hemorrhage, leakage of amniotic fluid, premature rupture of membranes or PROM, and potentially triggering preterm labor. Alloimmunization is also a risk if anti-D isn't given appropriately.
And risks to the fetus.
The most feared risk is procedure-related fetal loss, meaning miscarriage or stillbirth. The current estimated risk with experienced operators under ultrasound guidance is low, around 1 in 400 to 1 in 900, but it's not zero. Other risks include direct fetal injury from the needle, rare with guidance, fetal-maternal hemorrhage, and complications from chronic fluid leakage like oligohydramnios leading to pulmonary hypoplasia or limb contractures like talipes, clubfoot.
Is there anyone who shouldn't have an amniocentesis?
You might.
A major contraindication.
Yes, amniocentesis is generally contraindicated in women who are HIV positive. The risk of vertical transmission of the virus to the fetus during the procedure is considered too high. In these cases, non-invasive screening methods like detailed ultrasound, NT measurement, and maternal serum screening are strongly preferred.
Okay, mastering the imaging and procedures is huge, but we also need to interpret key clinical lab tests. Let's start with something fundamental, examining the urine. Collection method matters.
It really does. For general analysis, physical, biochemical, microscopic, the first morning urine specimen is best because it's the most concentrated, making abnormalities easier to detect. But if you're specifically looking for infection, for a urine culture,
You need a clean catch.
you need a clean catch midstream urine sample. This involves cleaning the periurethral area, starting the stream, stopping, collecting the middle portion of the stream into a sterile container, and then finishing. This minimizes contamination from bacteria normally present near the urethra.
Let's focus on testing for protein. The old-school heat and acetic acid test still works, right? How does it differentiate protein?
It does. You gently heat the upper portion of urine in a test tube. If it gets cloudy, it could be protein or it could be phosphates, which are common. The key is then adding a few drops of dilute acetic acid.
What happens then?
Acetic acid will dissolve phosphate crystals. So if the cloudiness disappears, it was just phosphates. But if the cloudiness persists or even increases after adding the acid, then you know protein is present.
Nowadays, dipsticks are more common. ELPA sticks, multisysticins. We need to know how to read the scale.
Absolutely. These use a colorimetric reaction, the protein error of indicators. The color change corresponds to the protein concentration. You have to know the scale your lab or stick uses, but typically trace might be around 0.1 to 0.3 grams per liter. It goes up incrementally, and 4+ usually signifies massive proteinuria, like 10 grams per liter or more. This is vital for diagnosing and managing preeclampsia.
Okay, testing for sugar. Benedict's test versus dipsticks.
Benedict's test is a classic qualitative test for reducing substances. It uses copper sulfate in an alkaline solution. When heated with urine containing reducing substances like glucose, but also lactose, fructose, etc., the copper is reduced, forming a colored precipitate.
And the color tells you how much.
Roughly. Pale green is minimal, maybe up to 100 milligrams percent. Yellow-orange, up to brick red, indicates a large amount, over 2,000 milligram percent. But it's not specific for glucose. Lactose can be present in late pregnancy lactation.
Whereas dipsticks like diastics are specific.
Yes, dipsticks for glucose typically use the glucose oxidase enzyme reaction. This is highly specific for glucose only. They give a quick, semi-quantitative result based on color change, and they won't react to lactose or other sugars. Much more convenient for screening for gestational diabetes.
And testing for ketones or acetone.
Ketones spill into the urine during states of fat breakdown, like in diabetic ketoacidosis or severe starvation hyperemesis. The classic lab test is Rothera's test, which uses sodium nitroprusside. A positive test shows a reddish-purple ring. The dipstick equivalent is ketosticks, which uses a similar reaction on a test strip.
Let's switch to blood tests, specifically for coagulation disorders. This is critical in obstetrics, especially with hemorrhage or preeclampsia. Prothrombin time, PT, what do we need to know?
PT, also called Quick's test, measures the integrity of the extrinsic and common coagulation pathways. The normal range is typically around 8.5 to 13.1 seconds, but this varies slightly by lab. A prolonged PT indicates a problem with clotting factors in those pathways.
The collection tube is absolutely vital here.
Crucial. For coagulation studies like PT and APTT fibrinogen, you must use a collection tube containing 3.8% sodium citrate anticoagulant, and the fill ratio is non-negotiable. Exactly 9 parts blood to 1 part citrate solution.
Why is that 9.1 ratio so important? What happens if the tube is underfilled?
Sodium citrate works by binding calcium, which is essential for clotting. The 9.1 ratio provides the precise amount of citrate needed to bind the calcium in that volume of blood, just enough to prevent clotting in the tube. If you underfill the tube, you have too much citrate relative to the blood.
So the excess citrate.
The excess citrate binds up too much calcium, and when the lab tries to perform the test by adding calcium back, the clotting time will be artificially prolonged. You get a falsely high PT result, which could lead to incorrect diagnosis or mismanagement, like giving unnecessary clotting factors. Proper fill is essential.
What lab values might suggest? Disseminated intravascular coagulation, DIC, a feared complication.
DIC is complex, but key indicators include thrombocytopenia, so a platelet count falling below, say, 70,000 per cubic millimeter. A low fibrinogen level fibrinogen is consumed during clotting, so a level below 100 milligrams percent is considered critically low. Prolonged PT and APTT are also common.
What about the breakdown products, FDPs and D-dimers?
Elevated fibrin degradation products, FDPs, indicate that clotting and subsequent clot breakdown, fibrinolysis, are happening. A level above 80 micrograms per milliliter is generally considered significant in DIC. D-dimer is even more specific because it measures breakdown products of cross-linked fibrin, which only forms in abnormal clotting states like DIC. A D-dimer level greater than 200 milligrams per milliliter is highly suggestive.
We need to be meticulous about which collection vial for which test. This impacts accuracy dramatically.
Absolutely. You can't just draw blood into any tube. For a complete blood count, CBC, hemoglobin, hematocrit, platelet count, you need an EDTA vial, usually lavender top. EDTA chelates calcium to prevent clotting, but preserves cell morphology.
What about blood sugar?
For measuring blood glucose, you must use a tube containing a glycolytic inhibitor, usually sodium fluoride, often combined with an anticoagulant like potassium oxalate, typically a gray top vial. The fluoride stops the red blood cells from metabolizing glucose in the tube after collection, which would falsely lower the result.
And coagulation studies again.
Citrate vial, usually light blue top, strictly adhering to that 9.1 fill ratio. Knowing your tubes is fundamental lab practice.
What about collecting cord blood right after delivery? Any specific precautions?
Yes. To avoid contamination with Wharton's jelly, the gelatinous stuff in the cord, you should collect the sample from the placental end of the severed cord, letting it drip or aspirating gently. Don't squeeze the cord, as that can lyse cells and introduce jelly.
What tests are routinely done on cord blood?
Standard tests include ABOR blood grouping, a direct Coombs test looking for maternal antibodies attached to baby's red cells, and possibly serum bilirubin if jaundice is a concern. These need clotted blood, red top. For assessing anemia or infection, you might check hemoglobin and do a blood smear. Needs ADTA blood, lavender top.
There are also specialized tests to detect fetal hemoglobin, distinct from adult hemoglobin.
Right. Useful in specific situations. The alkali denaturation test, Singer's test, can help determine if blood seen vaginally during an antepartum hemorrhage is maternal or fetal. Fetal hemoglobin, HbF, is resistant to alkali denaturation, while adult hemoglobin, HbA, is not.
And the Kleihauer-Betke test.
The Kleihauer-Betke KB test, or acid elution test, is more quantitative. It's used to detect and quantify fetal red blood cells that have entered the maternal circulation. This is crucial for determining the appropriate dose of anti-deimmunoglobulin needed after potential fetal-maternal hemorrhage in Rh-negative mothers, and for assessing the severity of the hemorrhage itself.
Let's talk about the glucose tolerance test, GTT, used to diagnose gestational diabetes. Procedure details matter.
Precision is key for a valid GTT. The patient needs adequate carbohydrate intake, at least 150 GATO a day, for 3 days prior. Then, after an overnight fast, 8-14 hours, a fasting blood glucose sample is drawn.
Then the glucose load.
Then the patient drinks a standardized glucose load, typically 100 grams or sometimes 75 grams, depending on the protocol being used. Blood samples are then drawn at specific intervals afterwards, commonly at 1, 2, and 3 hours for the 100-gram test, or 1 and 2 hours for the 75 GATO test.
And the collection vial needs
That sodium fluoride inhibitor again to prevent glycolysis in the tube and ensure accurate glucose measurement.
We sometimes use rapid bedside tests like dextro sticks.
Dextro sticks and similar glucose meter strips provide a quick, semi-quantitative estimate of blood glucose using the glucose oxidase peroxidase reaction. They're useful for screening or monitoring, but require careful technique, timing the reaction precisely, wiping the strip correctly, and they aren't as accurate as laboratory testing for definitive diagnosis.
Finally, let's touch on cytology, specifically cervical and vaginal smears in pregnancy.
Cervical cytology, like a pap smear, isn't routine during pregnancy unless indicated for screening or follow-up of prior abnormalities. The main goal is to exclude premalignant or malignant lesions of the cervix.
What about vaginal cytology, the cytohormonal study?
This is less common now, but historically used to assess the hormonal milieu, specifically the progesterone effect. A smear is taken from the upper lateral vaginal wall, stain, tuberculose stain, and examined microscopically.
What indicates good progesterone effect?
A strong progesterone influence is shown by a predominance of intermediate cells, particularly navicular cells, which are boat-shaped intermediate cells with folded edges. This pattern suggests good placental function and progesterone support for the pregnancy.
And signs of progesterone deficiency. What's the karyopenitic index?
Progesterone deficiency, or relatively higher estrogen effect, is suggested when those intermediate to navicular cells are replaced by more superficial squamous cells. The karyopenitic index, KPI, quantifies this. It's the percentage of superficial cells that have small, shrunken, darkly stained nuclei, pagnotic nuclei. A rising KPI indicates waning progesterone effect.
What clinical situations might show that?
This pattern might be seen in cases of threatened or missed abortion, placental insufficiency, or approaching post-maturity, reflecting inadequate progesterone to maintain the pregnancy environment.
Wow. We have covered an immense amount of ground here. From the physics of piezoelectric crystals and Doppler shifts, all the way to the critical 9.1 citrate ratio for a PT tube and the meaning of flow patterns in tiny fetal arteries.
It's truly a deep dive. We've gone from understanding the fundamental physics, like acoustic impedance mismatch creating echoes, to the specific chemistry, like sodium fluoride stopping glycolysis in a glucose sample. We've hit the non-negotiable safety rules that 5 rad limit, avoiding first trimester radiation, and link them to clinical practice like the 10-day rule.
And the numbers.
The numbers are everything. Knowing that 1200 beta-HCG is the threshold for seeing a sac with TBS, that below 70,000 platelet signals concern for DIC, that an MCA velocity over 1.5 mum means prepare for potential transfusion. This level of detail, this precise knowledge, is what separates basic competence from true professional mastery in this field.
So, reflecting on all this, what's the final thought for you, the clinician striving for this level of mastery? What does holding this incredibly detailed technical knowledge really mean?
That's a great question to end on. I think it boils down to this. How does knowing all this intricate detail translate into providing the absolute best, safest patient care? The sheer technical burden is immense, but being able to recall and meticulously apply something like the 10-day rule, or understanding the profound consequence of simply underfilling a citrate tube, it shows that this high-level knowledge isn't just for exams.
It's about safety through precision.
Exactly. It's fundamentally a commitment to patient safety that's enacted through meticulous, almost obsessive technical execution. The precision in the physics of ultrasound, the timing required for a GTT, the specificity needed in interpreting Doppler waveforms or lab values, these aren't just academic details. In obstetrics, they are the very substance of high-quality, life-preserving care. The details are the care.